and thank you for the invitation to speak here. I want to say that I will not present big solutions. I think, as Bernard already told you, development in mental health is basically a development in culture, it's development in people. And what I want to share with you today is some ideas that have inspired us in the Netherlands in the developments we have made. First, to start, I think you cannot think about mental health and mental health organization without asserting the fact that a lot of people are potentially people in need of care. In the Netherlands, lifetime need of mental health is 1 out of 2. In 1 year, it's 1 out of 4. So that's a lot of people. And at this moment, we are able to give care, professional care, to 6% of the population, which is a lot. I can imagine that's not close to what's possible here in Greece. And the severe mental illness population is 1%. This already shows you one thing. If you want to rely on mental hospitals, it will never solve the problem. There's an ethical issue not to put all your money in the mental hospital, because that's not a solution for a lot of people. So what have we done? What we've done in the Netherlands is try to make a difference between those large populations of mental health patients. You can say one group is the shadow disorders. Basically, those are the people with mental health problems that don't really need care. They might need some kind of coaching, but do not need professional care. And then you have common disorders, and you have the severe mental illness patients. And in the common disorders, you have people in active treatment and people in disease management. Common disorders are basically anxieties, depressions, addictions, personality disorders, sometimes autism. But making choices is often making a choice for putting the priority in severe mental illness. I think it's a challenge, basically. But over the years, I became a little bit more of a skeptic on the issue of prevention. I think the Netherlands has showed that prevention doesn't work. The only thing that prevention does is treating light patients leads to treating 10% and 50% of your population with mental health solutions. I don't think that's a good solution. So we have to think about how to manage those large numbers. What we've done is formulate a consensus definition on severe mental illness. Of course, that consensus definition says that it has to be a severe mental illness that's not in a remission and doesn't reach remission very easily. It's also people who have disabilities, who are not able to function on different terrains in their life. And the interesting part is that for the severe mental illness population, both issues are interrelated. What does that mean? You might have someone with a depression. When you treat your depression, all the functional problems will be able to recover automatically. In a severe mental illness population, you have those issues interrelated, which means that people have a severe depression, but when you treat the depression, the societal issues will re-engage that depression, will re-activate that depression. So it's impossible to build a mental health system that just works on one dimension. The effects are long-lasting, and the treatment needs are basically network needs. You need to have an integrated system which is able to cover the different kind of domains. So the most important issues in that definition of severe mental illness are basically that interrelation between disability and the mental health problem SEC, and the fact that intervention strategies have to be interrelated. Most of the severe mental illness patients are in the age group of 18 to 65, but there is a group in the younger patients, and there is a smaller group in the older patients. The smaller group in the older patients has to do with something that's very different dramatically, but the survival issue of severe mental illness patients is low. They live 15 years less, 15 to 20 years less. So the consequence is that in the 65 plus group, you have not that much severe mental illness patients. It's an important group anyway, but it's a small group. And the population prevalence is larger. Which helped us a little bit was to acknowledge the fact that basically that severe mental illness population cannot be defined by saying, oh, that's the schizophrenic population. No, the severe mental illness population is a mixed group. But in different kind of diagnostic categories, you will have different kind of prevalences and that's severe mental illness group. So anxiety will result in a lower proportion of severe mental illness than, for instance, schizophrenia. And the result is that the group is also mixed. Important issue, even in the Netherlands, which is a highly densely populated country, we have prevalence differences up to 6 times the number of patients when you take a catchment area of 5,000 to 10,000 patients, 10,000 people. And that's important. You have to realize that you cannot plan mental health services on population alone. You have to look at different characteristics of the population. Demography, urbanicity, social economical status, migration, health index. You can use different issues for that. But one of the consequences is that in large cities you have a high prevalence. If you solve mental health problems in large cities, you probably solve 60 to 70% of the problems in your country. When I started working in psychiatry, I was taught that mental health patients, severe mental health patients, are eternally moving to nowhere. And being young and wanting to change people, I learned to put that in front of my desk, this picture from Escher. People going around, moving to nowhere. Over the years, we have come to understand that this is not a right way to describe that population. But one of the issues that leads to that idea that chronic mental patients are eternally moving to nowhere is that we are desperately searching for interventions that are kind of push-button interventions. You just put the medication in and it has to work. And if it doesn't work, we don't know anything anymore. You have a non-responsive patient or an untreatable patient. And that means that sometimes searching for efficiency in your mental health system leads to a differentiation between patients with good prognosis, where it seems to be adequate to invest, and people with poor prognosis, which you leave over to a welfare system, where the welfare system caters for whatever is missing.